For giving me the opportunity to talk with you today. I'm very much going to focus on the issues as we see them in the children's clinic for children and young people. But for those of you who perhaps weren't diagnosed until adult life, I suspect many of you can reflect back and think that in retrospect many of you probably did have symptoms in childhood. So it's a relatively uncommon condition in children, although, as I say, and you'll be the experts in this, but I think many adults do report that retrospectively they did have symptoms in childhood. And just to give you a bit of a flavour of the relative numbers that we see, in our clinic in Birmingham we see just over 100 boys with Duchenne, but we have fewer than 10 boys with Becker Muscular Dystrophy at the moment in the clinic. And I see boys from birth to 16 or 18. And I'll come back later to explain a bit about why I put 7+2 there, because that's a bit coded, isn't it? And again, as you've heard from David, it's so important to emphasise that the spectrum of the motor symptoms is so wide. So the more severely affected boy or young man with Becker Muscular Dystrophy will be not very different from those at the very best end of the Duchenne muscular dystrophy spectrum. And that's why this term dystrophinopathy is sometimes a useful one for us as doctors to use. And then at the other end of the spectrum, there will be boys who have very little in the way of motor symptoms, problems with their walking and weakness at the time when we see them. So I'll just run through the symptoms that we see in the clinic in children. And the ones you would think about immediately are those with the motor symptoms, the problems with the muscles themselves. But as I'll come back to say, in fact, that's not always the way in which children present and become diagnosed with Becker Muscular Dystrophy. And I think that's probably different from adults. But the motor symptoms are very similar to the ones you've already heard about. So some boys do tend to walk on tiptoes and may do that from a very early age, and that may be the only symptom that they present with. There are lots of other reasons for children to walk on tiptoes, but Becker Muscular Dystrophy is one of the ones that a paediatrician should be thinking about. Muscle cramping with a symptom in adults, and that's not an uncommon symptom in children and young people. And the calf enlargement as well may be something that parents notice from quite early on. Although the significance of that is not always apparent, particularly if there's been no family history of the condition. And most of the boys that we see, their parents have probably never heard of muscular dystrophy at all, let alone Becker muscular dystrophy, so it is a new thing for them. Then as time goes on, some of those children will have difficulty with running and climbing, so they can manage to join in with activities at school, but the sort of more active end of those symptoms is more difficult. And as I've said, the condition is a very wide spectrum, so those boys who are most severely affected may be struggling to walk by the time of transition into adult services, so by 16 to 18 years or so. So that's kind of the typical presentation, if you like. That's how you think that, or how doctors will think that they will make a diagnosis of Becker Muscular Dystrophy, that it will be a child who's having difficulties with walking. But as I've said, there are other ways and other symptoms with which children may turn up to see a paediatrician. And one of the biggest group, actually, for us are those children who are actually what might be described as pre-symptomatic. So actually, they don't actually necessarily have any problems of weakness or difficulty with walking at the time when they're first seen. Some of those may, of course, be because there's a family history, so people are aware that there are other affected people in the family with Becker Muscular Dystrophy and may wish to know if their child is similarly affected. Now, there are some difficulties or potential ethical issues there about whether it's correct or appropriate to do genetic tests on young children who don't have symptoms. And in most genetic conditions, we would not look to test for a genetic disorder in a child until that child was old enough to make that decision for themselves, that they wanted to have that test and to understand the implications of having that test. The exception to that would be is if it's important to know from a medical point of view whether somebody's affected by a condition. And so you could argue that for Becker Muscular Dystrophy it may be important to know because of some of the other issues I'm going to come on to, such as, for instance, the problems potentially with general anaesthetic drugs. So it needs very careful consideration before you go into pre-symptomatic genetic testing of a child. One option may be to say, well, we don't know whether this boy is affected, we should wait and see if he develops any symptoms, or we should wait and see what that young person themselves want to do as they get older. But perhaps in the meantime, do we manage him as if he does have Becker Muscular Dystrophy? In that case, you might as well say, well, actually, probably we should test that boy anyway. But it's a discussion that, as parents of young affected boys or potentially affected boys, needs to be balanced fairly carefully, really. The problem with general anaesthetics is that, as many of you, or all of you, I'm sure, are aware, is that if you have Becker Muscular Dystrophy, you can have a reaction to some general anaesthetic drugs which can lead to the breakdown of muscle protein and produces this dark coloured urine, as you sometimes get with excessive exercise, and that can cause damage to the kidneys because the muscle protein clogs up the kidneys when that protein is present. Now that can be entirely avoided as long as certain general anaesthetic agents are not used. So this, in general, only occurs if a pre-symptomatic person is given a general anaesthetic with those drugs. And we have seen that. We have seen a boy who's having a minor operation, completely unconnected with muscular dystrophy, and then has a severe reaction to anaesthetic, and then you're able to make the diagnosis later on in that boy. And you obviously want to avoid that happening if you can. The other way in which young boys may present to paediatricians is for those, that relatively small group of boys with Becker Muscular Dystrophy who have involvement of the brain producing learning difficulties. And as you've heard from David, that can be a feature in a minority, but some people with Becker Muscular Dystrophy. And very occasionally those learning difficulties can be quite severe and can be associated with autistic features. So for those boys who often do not have much in the way of muscle weakness at that point, they will be seen and assessed by paediatricians because of their learning problems and their educational difficulties. And that's the more dominant problem in their early childhood years. Sometimes in those boys, probably because they don't have any muscle weakness or apparent symptoms, the diagnosis of Becker Muscular Dystrophy is not made for quite a few years after the learning and behaviour problems have become apparent, because everybody becomes very focused on that. I think that paediatricians now, and particularly community paediatricians and paediatricians in child development centres who are seeing children with severe learning difficulties, are much more aware of this as a potential diagnosis in boys who have severe learning problems. So I hope that this is less likely to happen. But if this is a boy whose muscle weakness is going to be at the very best end of the Becker spectrum, and maybe they won't have weakness until their 20s, 30s, 40s, they may still have the features of these non-progressive learning difficulties, which means they're seen by paediatricians in early childhood. So how is the diagnosis confirmed in children? Because sometimes it's not straightforward, particularly if children have turned up without the typical muscle symptoms. The tests are the same as David has described to you for adults, and it's particularly important that we put that whole picture together. You need all of the things really to be sure of the diagnosis of Becker Muscular Dystrophy in childhood. and that includes the clinical picture. So I'm sure all of you, when you were being tested for muscular dystrophy, the first test you probably had was this CK test, and this is a screening test. So this is a chemical that's present within the muscle cell, and if there is damage to the muscle, it leaks out into the bloodstream so that the level in the blood is much higher than it normally is. So the normal level in the blood is usually several hundred, perhaps 200, and in people with muscular dystrophy the level will be several thousands. It might be 5, 10, 20,000. That sometimes worries people, but the level itself isn't dangerous. It doesn't tell anything about the severity of the muscular dystrophy. It just tells us that somebody has muscular dystrophy. And then we need to go on and do the specific tests to confirm the type of muscular dystrophy. So there are 2 specific tests that are done, and not everybody needs to have both tests. So for most people, the genetic test, a blood test looking at the DNA, will be enough. But for some children and some adults, we also do a muscle biopsy because that helps us be firmer in the diagnosis. And then, as I've said, it's absolutely vital that we look at the clinical picture. So if I see a young child who I think has definitely got a dystrophinopathy, so they've got Duchenne or Becker, even depending on the results, I need to look closely at how their clinical picture is. Is their weakness what I would expect for a child of this age with Duchenne muscular dystrophy or Becker muscular dystrophy? And ultimately, it's that clinical picture which determines the label we may put on some child. I'll just very briefly go through this, and David has been through the genetics with a very good introduction. So this really is building on the Lego blocks theory, and this is just to try and explain how the results of the genetic test can help us say whether this is more likely to be Becker muscular dystrophy or whether it could be Duchenne muscular dystrophy. So David's talked about the gene as a code for proteins, and within each gene there are letters that code the individual building blocks of each protein. Each protein is made up of a series of amino acids, and when they're all strung together in a particular sequence, that gives you a particular protein. And within the gene you have 3 letters, and each group of 3 letters codes for that amino acid. And when the cell makes the protein, it has to be able to read that code to make the right sequence of amino acids to make the right protein. So, you know already that the gene for Duchenne muscular dystrophy and the gene for Becker muscular dystrophy, it's the same gene. So why is it that for some people, some very young boys who have the most severe type of Duchenne muscular dystrophy, it's the same gene that, in which a misprint can produce an adult man in his 60s with mild weakness? So this is an analogy to try and explain that. So here's a code that I've just put here. So it's a 3-letter code. The man and the dog ran for the bus. We can all read that. What we've done here in the next line is just remove those 4 letters, H-E-M-A. So we've not taken a lot out, but it's not a multiple of 3. And so when we try and read this code now, 3 letters at a time, it doesn't make any sense compared with the original code. And that's what happens in Duchenne muscular dystrophy. The way the misprint in the gene works means it disrupts your ability to, or the body's ability to read the code, and so you get none of the protein, none of the dystrophin produced. Now, on the following line, we've taken out and the dog, so it's similar size, sort of bit missing, but it's a multiple of 3. So now we can still read this sentence. It's shorter, but it still kind of makes sense. And that's what happens in Becker muscular dystrophy, that you get a disruption of the gene, a misprint in the gene, but the gene can still partially function and produce a shorter or smaller amount of the dystrophin protein. And so when we get genetic reports about analysis of the dystrophin gene, the laboratory are able to tell us whether the mutation is what's called an outframe, so it means you can't read the code at all, and that's much more likely to be Duchenne muscular dystrophy, or an in-frame mutation, which may still lead to the production of some of the protein. And this is what muscle biopsies look like. And so we look at two things on a muscle biopsy. One is how the muscle fibers look under the microscope. And so on the left here, that's normal muscle at the top, and we're looking at the muscle fibers sort of end on. You have to kind of imagine it's like sort of bundle of sticks all tied together and cut into slices. And you can see that muscle fibers here all look very sort of even, and they're all nicely tightly packed in together. And underneath is a muscle, somebody with muscular dystrophy, where some of the muscle fibers have been destroyed and replaced with fibrous tissue, sort of gristly stuff in between the muscle fibers. And then the laboratory will look at the dystrophin in the biopsy. So, and they apply various chemicals that will stain for the dystrophin, which is around the edge of the muscle fiber, so it's like doing a drawing really. And at the top here, there is a normal muscle biopsy, and you can see these thick brown lines outlining each muscle fiber. And in Becker Muscular Dystrophy, there is a reduced amount, or it may be patchy in some fibers and not in others. And in Duchenne Muscular Dystrophy, it's not present at all. So when we're making the diagnosis, we put together all the information from the muscle biopsy of when has happened, together with the specific genetic information, together with the clinical picture. Even when we do that, in very young children, it's sometimes not easy to make a firm diagnosis. And that's why when I said we see 7 or 9 boys with Becker muscular dystrophy, that's because it's not very easy to be sure in those very young children as yet whether they are going to be within the Becker muscular dystrophy spectrum or at the better end of the Duchenne spectrum. And that's particularly true in a very young child who's perhaps only 2 or 3 years old, particularly if they have quite severe learning difficulties, and that's why they've come along in the first place, to know for sure how things are going to go. So sometimes paediatricians looking after children with muscular disorders have to have an open mind, or keep things under review in those first few years after we've done the tests. So what about the medical follow-up for children with young people with Becker muscular dystrophy? Well, for those pre-symptomatic children, it's important they have a cardiac review. Again, as David has said, we would start those in young children, and they have echocardiograms on a regular basis, about every 3 years or so. Advice about managing general anaesthetics and exercise, and you're going to hear from Jane, I think, about exercise more. Genetic referral for the parents, and very importantly for the young people themselves once they reach 16, and information and support from care advisors and particularly those pre-symptomatic children and young people. I think it's also very important not to over-medicalise things. You don't need to be coming to the clinic every 6 months to see me. We need to make sure these things are in place, and then just try and keep contact from time to time. For those children who do have motor symptoms, they need to have all of those things, but in addition, we muscular assessment to look at muscle strength with our neuromuscular physiotherapists, and particularly importantly, liaising with the local services. Children with neuromuscular conditions tend to be seen in regional clinics, but most of their day-to-day care and the effect on their day-to-day lives with school and physiotherapy and so on is in their local area. So, it's it's very important that children with Becker Muscular Dystrophy are in touch with those local services. One of our roles in the neuromuscular clinic is to liaise with your local physiotherapist, your local community paediatrician, and with schools. So what do schools need to know? Becker Muscular Dystrophy is not a common condition. The vast majority of schools will not have heard of this condition, will not have had a boy with Becker Muscular Dystrophy in the school. So it's very important that they have that information and knowledge, and our care advisors are very good at going out to schools and talking things through. And like everything else, just knowing about conditions helps, and schools are less worried then. Usually the local physiotherapist will visit the school and talk about the needs, particularly for those boys and young people who have motor difficulties, particularly in secondary schools, and plan ahead for transitions into college. It's important to think about what is realistic and appropriate for a boy to be doing in PE. We don't want boys to be either over-exercised to the point of muscle damage, or to be richly humiliated in PE, as many of us maybe have been in the years gone by. But it's also important for boys to remain healthy and fit. For those boys with learning and behaviour support, it's important that the school understands the context of their learning difficulties within the diagnosis of Becker muscular dystrophy.